And she begins to think a bit about the fact that her disease is physical, but that her experience is holistic, that her experience encompasses her whole life, and that managing this disease, the medicines as well as more broadly the behavioral elements, really takes all of her. And so when she's introduced to her personalized guided program, she's willing to give it a try. She recognizes and identifies with the fact that she does have complex thoughts and feelings about her disease, feelings of anger, fear, guilt, shame, that get in the way of her ability to proactively manage that disease in therapy. Mary can engage with her program through multiple channels. She chooses to engage primarily through the web. She has internet access at home, and she feels comfortable using the internet. But she also has other channels she can engage through if she chooses to, and some channels like text and mobile and email complement her web experience. One of the first things Mary does is she picks a virtual guide. The virtual guides are virtual, as the name suggests, stick with the patient throughout the program, and can answer questions based on a heuristics engine and a database. And Mary likes the idea of someone who will be there with her, sort of like you might call a good dog, always there but never judging. Mary's introduced to her own personal program that's specific to her and to what she needs to deal with. And you see on the left side here a web shot with 6 steps. And not every program is 6 steps, but they're never 6,000 steps. They're a small handful of steps to accomplish a specific set of behavior changes. And you see those 6 steps, which are designed to introduce Mary to some of the key knowledge that she needs in a way that's relevant to her, help her raise and begin to address some of the complex thoughts and feelings that underlie and surround her disease, and then help her learn the practical skills to manage both the therapy and the disease more broadly. And then you see on the right 2 elements of mobile functionality, reminders and tracking, integrated functionalities built into Mary's specific program. So I mentioned before that one of the first things Mary did was complete a simple assessment. And you see here the 2 core assessments around barriers to adherence, as well as learning style. Adherence on the left, learning style on the right. The way the system works is that it starts with a very small number of questions, 5 to 10 usually to start. And then over time, as the individual uses the program more, the system will ask more questions to continue to hone and personalize the experience. But it starts with a small number, so it's not overwhelming, and begins to give the users that flavor of personalization very quickly. So what do we mean by personalization or tailoring? So this is an example of a learning or knowledge-building element. And this is tailored to how Mary learns in terms of, is she a visual learner? Does she learn by reading? It is topical, relevant to where she is in managing that disease and therapy. It's interactive with assessments for understanding. And it has specific next steps that follow from that learning. So learning tailored to where Mary is in managing her disease and how she learns. Mary also begins to work on some of her thoughts and feelings, some of her feelings of like shame and anxiety and fear about where this disease is going next. And she's able to work through these cognitive behavioral exercises in a way that, again, is judgment-free and private, and allows her to think and raise these issues in her own mind. Exactly the sort of thing that you would do with a therapist, but not necessary to go to a therapist or pay for a therapist in order to go through it. Mary does personalized exercises that are specific to the thoughts and feelings that she's working on overcoming. Her guide is with her along the way. She has the ability to ask questions if she has questions. And the system periodically asks her to rate her thoughts and feelings or score her thoughts and feelings in order to, both for the system's benefit to continue to hone the program as well as for her benefit to see and track progress. After Mary spent a little bit of time with the program, she decides to involve her husband in the co-patient portal, the element of the program designed to help family members both learn skills to be productive supporters, but also learn themselves how to survive what can be a difficult experience, supporting a family member with a serious or complex disease. And in this case, Mary and her spouse had previously had a number of disagreements relevant to her health and her management of that health. And not to say that those disagreements vanish overnight, but her husband now feels less out of the loop, less powerless in helping Mary with these issues, and like he actually has some tools to be supportive and objective. So at the end of the day, why does Mary choose to engage with this program? It takes a little bit of time, a little bit of effort. It may be somewhat difficult to think through some of these thoughts and feelings and to reach out to a family member, to engage a family member. So why does she do it? Well, patients say, I like how it's personalized and how it grows as I grow. It feels like it gives me a lever to actually gain some control over a part of my life that I may never have had control over, or perhaps recently diagnosed as a part of my life that I'm very fearful about and would love a way to get control over. It's reassuring, and I like the steps. It helps bring out feelings that I wasn't aware of and that I might not have wanted to talk to my husband, my doctor, or even my therapist about, but feelings that I recognize are inside me and that I do need to address. And finally, for those folks who do include a family member, we do hear regularly the concept of translating energy that had previously been devoted to nagging into energy devoted to something more supportive and constructive. So that's Mary's experience. So now let me share a little bit of data on are these experiences valuable? Do these experiences actually change meaningful metrics of health? So I'm going to show you two relatively small-scale studies that we have completed. We have several other studies that are in other stages, but I'm going to show you two studies that we've completed. So the first study is a study specifically of medicine adherence measured by refill rate. This is in a diabetic population run in partnership with a health system in the U.S. Called the Primary Health Network, which is affiliated with the University of Pittsburgh Medical Center. And it's a small-scale study. 50 diabetics started, 42 completed, 18-month study, single arm. Baseline was established in the first 6 months pre-intervention by measuring refill rate without any intervention. And so what we're measuring here is for this group of diabetic patients who are taking a variety of medicines. They're taking medicines for their diabetes. Well, let me be clear. They're prescribed to take a variety of medicines. Medicines for their diabetes. Some of them have cardiovascular medicines, depression, asthma, etc. And so what this is a measure of all the medicines their PCP thought they should be taking, how many were they refilling? So not just new medicines, but all their medicines, how many were they actually refilling? And refill was defined as refilled within a 2-week buffer of the time they should have refilled it. So for 6 months, we measured their change in refill rate. The vertical axis is change in refill rate. And there was no kind of natural or inherent change. They stayed at about a 42% refill rate across their full range of medicines. We started the intervention September 1st, 2009 through their primary care physician's office. They were introduced to it through their PCP, or usually a nurse in their PCP's office. And we measured the change in refill rate. Did they increase their refills? And they did, in fact, during the 6-month intervention period. We then stopped the intervention after 6 months in order to measure the durability of the changes. Had they actually learned new behaviors that were durable and actually stuck around? And while we've had some degradation over the 6-month follow-up period, it's held fairly steady at about a 75% refill rate. So for this population, we were able to show a quite substantial increase in refill from 42% to 75%. And then in the second study, also in a diabetic population, in this case, 2 arms, 100 patients started the study, and also administered in a health system environment. And the goal in this study was to measure impact on 4 cardiometabolic markers: LDL, blood pressure, BMI, and A1C. The placebo in this case is normal lifestyle and behavioral counseling for a diabetic patient, which essentially consists of a nurse or doctor saying you should lose weight, should consider a daily walking program, you should quit smoking, here's a community smoking cessation program. I think that in our trial that was actually a more intense level of intervention than your average diabetic gets on a regular basis. But despite that, our comprehensive program showed a statistically significant improvement versus that placebo in systolic blood pressure, BMI reduction, and A1C reduction. And so finally, summing up our value to our biopharma clients, differentiate to prescribers, show that your therapy is easier for patients, more valuable for patients, and in some cases less hassle and less frustration for the prescriber as a result of the additional support the patient receives. Engage with and directly support patients and family, and help patients and family better manage difficult disease and therapy. In some cases, REMS and other regulatory requirements are requiring that biopharma support patients, educate patients, and so that can be a relevant element. Ultimately, if patients take their medicines as prescribed and if they manage other elements of disease, that will impact health economics. We don't yet have any data on the impact of health economics, but certainly if we continue to show data on improving adherence and improving markers of health outcomes, that will eventually translate into health economics. And then finally, for the brand team, the managed markets team, the sales team, the underlying data with analysis tools to track and learn from patient and family usage. So that's what we do, behavioral approaches to therapy adherence, and I'd be happy to take any questions you have.